Hi, I would like to discuss one of my patients who met us with a history of 1.5 months old elbow pain. She was having the pain during gripping activities, during cooking related activities, and the rest was not relieving the pain. She took some over the counter medications which was not giving any permanent solution. So she met us. The pain was mostly in the lateral elbow. We did the Mills Manaver, Cousins test, the grip test, everything was positive. So we provisionally diagnosed her as having tennis elbow type of symptom, which is always called as lateral elbow tendinitis. We started with the physiotherapy sessions for about 2 weeks, and then she said the pain is on and off still, it's not really getting better. So I told her to take rest because it's a lateral elbow tendinitis, right? So I strongly believe tendinitis needs a little bit of load reduction and activity modification. So we told her to reduce the activities what she does in this hand and do the activities by the other side. So she did that, by the way, religiously, but in spite of that, the pain did not go away. Rather, she slowly started to say that the pain is migrating to the medial aspect, and then I was palpating the medial muscles. The frontal teres was painful, and then I did that resisted flexion for the wrist that was producing pain over the middle epicondyle. Then I got little confused whether she's got both tennis elbow as well as golfer's elbow. Hardly anyone would get both tennis elbow as well as golfer's elbow together, so it was kind of surprising me. Then I still gave treatment for a couple of more sessions, and then thought, okay, maybe once in an odd patient may get both conditions together because of some unaccustomed activities she would have done. As days passed by, she did not get any improvement. Upon further questioning, she said that her mother used to have rheumatoid arthritis, but she said that she is not having one, and she said that I don't have any pain in the fingers and I don't have morning stiffness here. So she was very much convinced that she don't have rheumatoid arthritis. Still, we wanted to rule out that because for us, if the pain is not going away with our approach, then we always want to do a blood test and see what else is there in the system which is contributing to the pain. The blood test that we recommended her to do was the CBC, ESR and CRP and HbA1c and the RA factor and anti-CCP. So these are all some of the inflammatory parameters that we generally recommend to our patients to rule out the systemic problem. Again, surprisingly, all these test parameters were negative, except that her HbA1c was at 6, which is a borderline diabetes, but for that it should not be this much painful. So we thought that it is a kind of atypical rheumatoid arthritis which is monoarticular in nature, which is seronegative in nature. So we recommended her to visit our rheumatologist. The rheumatologist also had examined her, and she thought that it could be a monoarticular form of rheumatoid arthritis which is falling under the seronegative category. Her claim was not every RA patient will be having classical distal joint exhibition and classical symmetrical joint exhibition. It could be even monoarticular, sometimes seronegative, which means that the blood test will not show anything pertinent to the rheumatoid arthritis, but still they'll be having a clinical features of rheumatoid arthritis. So she subjected this patient with disease modifying anti-rheumatic drugs, and within 2 weeks the pain disappeared. And today it's been almost 2.5 months since I started seeing her first. No pain. I called her just for the sake of my learning, and then I did the Cousins test, the Mills test, palpation test for all the muscles. Everything was negative. There was no pain during day-to-day activities. There is no pain during gripping activities. So the pain got disappeared. So this tells one thing, that not all tennis elbows, but because tennis elbow is a form of tendinopathy, you know that ankylosing spondylitis patients would have tendo-Achilles pain. Okay, enthesopathy is a form of rheumatic exhibition. How ankylosing spondylitis patients do exhibit bilateral or unilateral Achilles tendon pain, similarly rheumatoid arthritis can exhibit pain in other tendons as well. So I saw a patient who was an young lady who had botanist deformity, but her age was only 25. It's very hard to say an young lady who are having botanist deformity without having a systemic manifestation. So we asked her to do a blood test. The RA factor value was skyrocketing, and she had a strong history of family history of rheumatoid arthritis. So these are some of the things that as a physiotherapist we miss, and we think all the pains are mechanical in nature, and day in and day out put them into some form of exercises or something like massage or cupping or dry needling. We keep doing one or other things to passively to make the people better. I understand the intent behind that. We all want the patients to get better, I know that, but we need to be having little bit of medical knowledge as well to filter out this type of people so that we guide them correctly to get appropriate treatment. So the essence of this message is to make physios aware of that sometimes seronegative arthritis do exist, which can exhibit in a very odd way. You never know. So, for example, it can exhibit in the thumb in the form of Dick-Waren's disease. It can be an RA. It can exhibit in the form of Baker's cyst in the knee. We think it's because of traumatic meniscal tears which is causing the Baker's cyst. It's not the case. It could be the RA. Sometimes people will come to us with a hallux valgus deformity. It could be an RA. So not necessarily all RAs must have the blood values positive. Not necessarily everybody should have bilateral symmetrical symptoms. So you need to consider these types of unique representation of RA as well. These RAs can be exhibiting as monoarticular, oligoarticular, or even polyarticular. So a good physiotherapist will make such precise diagnosis and give a right intervention. If he can't give the right intervention, he will refer to the right people to get the right intervention. I hope you understood certain things today and use it for your future patients. Alright, cheers.